We're going to talk a little bit about iliac vein compression syndrome and build on Dr. Cooler's earlier discussion. Nothing to disclose. So my first case is, I'm going to jump right into the cases. 38-year-old woman, several years of lower extremity edema. She had a left GSV ablation about 3 years ago outside of our system and now has worsening edema, particularly at night. It's now painful. It's interfering with her job. She's crampy, itchy, the whole kit and caboodle in terms of symptoms. And she has no personal or family history of VTE. We did perform a venous insufficiency ultrasound. She had significant superficial venous insufficiency at the GSV level, both in the thigh and the calf, and some suggestion maybe of some deep venous insufficiency, particularly in the popliteal on the right, but the left looked okay. We were concerned about an outflow lesion, and she had an MRV done, which you can see where the arrows demonstrate here, pancaking of the left common iliac vein as it goes into the IVC, suggesting that she may have iliac vein compression syndrome. So we brought her to the lab, and to the points that were made earlier, venography can sometimes be deceptive. I mean, you can see in here, maybe there's a suggestion of a stenosis, but it certainly looks okay. But when you do IVUS, this is pullback here, you can see that the vein gets quite stenotic. I'm going to just fast forward it a little bit. You can see here, it's being compressed by the artery and very, very stenotic there. So confirming the diagnosis, we got our reference vessel, which was somewhere in the neighborhood of 15, and then the actual lesion showed an area of only 67 and quite a degree of stenosis. So we used a Venovo 16 by 80 stent, and we got a very, very nice angiographic result. Post-IVUS suggests a well-expanded stent, and the area of compression is now gone, with an area of 177 now. So, after this, she felt tremendously better. She was seen about a month later in clinic and felt a lot better. And I showed a case of a patient that is sort of typical of what we really think about when we think about this disease, and I'm going to contrast it with a patient that we don't think about with this disease and show how, the classic ambulatory 35 to 40-year-old, 25-year-old woman is not the only patient that has this. And to Chris's point from earlier, I think this is still a syndrome that's underdiagnosed, but maybe overdiagnosed in the people that actually do some of this work. And so I think finding that balance is going to be important. So this next patient is quite a different history. A 72-year-old man who's a computer programmer with a relatively benign past medical history, no VT risk factors, and up to date with his cancer screening, presented to an outside hospital with segmental as well as main PEs and what they considered as a significant pulmonary embolus presentation. And he was transferred to our center for advanced therapies. So when we met him, his right ventricle was severely dilated, his right ventricle was severely hypokinetic, he had an elevated troponin, NT-proBNP was elevated, and his duplex ultrasound was actually negative for DVT and certainly fit the picture of a hemodynamically significant PE. We brought him to the lab, and the reason he was transferred to our center was for consideration for catheter-directed thrombolysis. But when we took him to the lab, his RA was 20, his right ventricle PA pressures were systolic were 84 with a mean of 52, and his mixed venous O2 saturation is 29%. His cardiac index was 0.97. I didn't share with you his systolic blood pressure. His systolic blood pressure was okay in the 120s, but he was definitely tachycardic, as you can see, to the 120. So certainly submassive, ranging into massive PE. And we were concerned that there may be an acute on chronic component here, given the elevated pulmonary artery pressures and the low cardiac index. And we actually put him on ECMO and did a pulmonary angiogram. So once we stabilized the hemodynamics, we could see bilateral filling defects and pruning distally, suggesting more of a long-standing or chronic picture. He underwent pulmonary thromboendarterectomy. His pulmonary pressures rapidly declined. As you can see, there's a mix of acute and chronic components to the clot, the white being more of the chronic variety, the red being more of the acute variety. He was started on anticoagulation with warfarin, And then he had a sort of a prolonged course coming off of the ECMO and was still in the hospital 23 days later, but his INR had been therapeutic while he was in the hospital awaiting rehab placement. Even though his INR was 2.7, he developed severe left lower extremity edema. His left CFV completely occluded. His left popliteal completely occluded. And the surgeon actually called me for an IVC filter, and I said, wait, let's see how far up this thrombus really goes. And so we got a CT venogram, and he had non-occlusive thrombus suggested all the way up to right below the renal vein, as you can see here, and then occlusive in the left external and common iliac veins extending down to the popliteal vein, as we saw in ultrasound, completely occlusive. So we brought him to the lab and did a venogram. You can see here the layered thrombus in the IVC, or at least the stenosis. Then we did an angiovac procedure, which is a suction thrombectomy catheter, and got a really nice result angiographically in the IVC. But you can see it's not perfect. There's still a little bit of thrombus left, and you can see now there's a hint of the left common iliac vein. So this is what we got out of the angiovac, and you can see this is actually fairly chronic appearing, but quite a lot of thrombus was evacuated. So we were on the right side. We went up and over, and because it was occluded, we decided to go up and over down the left side and do a mechanical thrombectomy using the Clot-Triever system, which is a mechanical thrombectomy system which essentially scores the thrombus, and as you can see in the left panel, allows you to pull it back, kind of like the clot staining, but a little bit different. And so we were able to get a nice result, as you can see from the left side, getting quite a bit of recanalization. But as you can see here, it's a little bit small, but there's a problem right at that left common iliac IVC junction. And get to the next slide here. So we did intravascular ultrasound, the mainstay of diagnosis, and you can see it gets very, very tight right in that area. So that was the IVC pullback, and now we're in the left external iliac vein. And we can talk about, stenting versus not in the setting of thrombectomy. There's still some thrombus here, but we really couldn't get good flow dynamics with just balloon angioplasty. So we've diagnosed iliac vein compression syndrome with quite a degree of stenosis right at that common iliac vein IVC junction. This was pre the dedicated venous stents that are there now. So we used a 16/90 wall stent, which you can see here restored flow and really got a nice result. And then this is right above that in the IVC. And just a demonstration of this was in the classic area that we sort of normally think about. So this was a very interesting case because this is somebody who probably had iliac vein compression syndrome for a long time, developed chronic DVTPs that were either undiagnosed, subclinical, what have you, developed some degree of chronic thromboembolic disease and came in with acute on chronic PE with shock, and we kind of unraveled this going backwards and got to what we hope is a root cause. He's about 4 to 5 months out now, doing very well in rehab. His leg is decompressed, and he's doing quite well. So, just summary points. Really, May-Thurner may present in atypical fashion, and we really do need a high index of suspicion. And as Dr. Collard mentioned, there are other sort of syndromes that you can have aside from the classic left common iliac vein IVC situation. Thank you for your time.